Alterations of digestive function. Anorexia, in this context, refers to a loss of appetite despite physiological hunger signals. It can be linked to nausea, abdominal pain, psychological stress, or even systemic illness. Often, anorexia is one of the first signs that something is wrong in the digestive system. It may lead to weight loss and nutritional deficiencies if not addressed. Vomiting is the body's way of forcefully expelling stomach and intestinal contents through the mouth. It can be triggered by a wide range of stimuli, including illness, stress, or toxins. This reflex is often accompanied by nausea, hypersalivation, and increased heart rate. Retching and projectile vomiting are specific variations with their own clinical significance. Constipation refers to infrequent or difficult defecation, and it can be a primary or secondary condition. Primary types include normal transit, slow transit, and pelvic floor dysfunction. Secondary constipation may result from medications, lifestyle factors, or systemic disease. Identifying the cause is crucial for effective treatment. The symptoms of constipation go beyond simply not having a bowel movement. Patients may report straining, hard stools, or a sense of incomplete emptying. Some even need to manually assist stool passage. Fewer than 3 bowel movements per week is often a red flag that warrants medical evaluation. Diarrhea involves the frequent passage of loose or watery stools and can vary in volume and duration. Large volume diarrhea is usually caused by excess water or secretion in the intestines. In contrast, small volume diarrhea often points to heightened motility or inflammation. Understanding the type helps determine the underlying cause. Diarrhea can result from osmotic imbalances, excessive secretion, or abnormal motility patterns. Each mechanism has distinct features and implications for treatment. Chronic diarrhea can lead to serious complications like dehydration and electrolyte imbalances. Managing the underlying cause is the key to effective care. Abdominal pain can be mechanical, inflammatory, or ischemic in origin. Parietal pain is sharp and localized, while visceral pain is dull and poorly defined. Referred pain is felt in a location distant from the actual problem. Understanding these patterns helps clinicians pinpoint the affected organ or tissue. Gastrointestinal bleeding is classified based on its location, either upper or lower GI tract. Upper bleeding often comes from the esophagus or stomach, while lower bleeding involves the intestines or rectum. Symptoms include hematochezia, melena, and occult blood loss. The body's response depends heavily on the rate and volume of bleeding. This final slide in the section summarizes how various GI dysfunctions present in clinical settings. Anorexia, vomiting, constipation, diarrhea, and GI bleeding all require different diagnostic approaches. Recognizing these signs early can significantly improve patient outcomes. A thorough history and physical exam are essential to guide further testing. Dysphagia, or difficulty swallowing, can arise from either mechanical obstructions or functional disorders. One example of a functional cause is achalasia, where the esophagus loses its ability to move food toward the stomach. This happens due to damage to the inhibitory neurons in the myenteric plexus. As a result, smooth muscle in the lower esophagus atrophies, worsening the swallowing issue. The manifestations of dysphagia range from stabbing pain at the point of obstruction to regurgitation of undigested food. Patients may also experience discomfort after swallowing, vomiting, or even aspiration. Over time, this can lead to significant weight loss. Management strategies include eating slowly, staying upright during and after meals, and consuming fluids with food. Gastroesophageal reflux disease, or GERD, occurs when acid and pepsin reflux from the stomach into the esophagus. This reflux damages the esophageal lining, leading to inflammation known as esophagitis. One common cause is a weakened lower esophageal sphincter, or LES. Conditions that increase abdominal pressure or delay gastric emptying make the problem worse. Common symptoms of GERD include heartburn, acid regurgitation, and chest discomfort. Patients may also report chronic cough, laryngitis, or asthma-like symptoms triggered by reflux. The discomfort typically occurs within 1 hour of eating. Proton pump inhibitors are the treatment of choice to reduce acid and heal the esophagus. Hiatal hernias occur when a portion of the stomach pushes through the diaphragm into the chest. There are 3 main types: sliding, paraesophageal, and mixed. Sliding hiatal hernias are the most common and tend to be less severe. Conservative treatment is typically used unless complications arise. This slide references surgical content and illustrates anatomical relationships involved in hiatal hernias. Understanding the precise location of the herniation is critical in differentiating between types. It emphasizes how anatomical changes impact GI function. These images are valuable for clinical visualization and surgical planning. Gastroparesis is the delayed emptying of the stomach in the absence of any mechanical blockage. It is often associated with diabetes, vagotomy, or fundoplication surgery. Symptoms include nausea, vomiting, abdominal pain, and feeling full soon after eating. Management involves dietary modifications and medications to stimulate motility. Pyloric obstruction narrows the passage between the stomach and the duodenum, making it difficult for food to pass. This can be a congenital defect or develop later in life. Common symptoms include upper abdominal pain, a feeling of fullness, and vomiting. Over time, prolonged obstruction can lead to malnutrition and dehydration. An intestinal obstruction prevents normal movement of food and fluids through the intestinal tract. It may be a simple mechanical blockage or a functional issue like paralytic ileus. Functional obstruction often follows surgery or results from conditions like pancreatitis. Treatment depends on the type and cause of the obstruction. This slide visually summarizes 4 common mechanical causes of intestinal obstruction. In Image A, we see a herniation, where a portion of the intestine protrudes through a weakened area of the abdominal wall, potentially trapping bowel segments. Image B shows adhesions, which are bands of scar tissue that form between bowel loops, often after surgery, leading to restricted movement and blockage. Image C depicts a volvulus, a dangerous twisting of the intestine that can cut off blood supply and requires immediate intervention. Finally, Image D illustrates intussusception, where one segment of the intestine telescopes into another, commonly seen in infants, causing obstruction and ischemia. Recognizing these patterns is key to prompt diagnosis and treatment. This slide expands on types of obstruction, particularly the clinical signs associated with them. In small intestine obstructions, patients often experience colicky, abdominal pain, nausea, and vomiting. Large bowel obstruction, on the other hand, tends to cause lower abdominal distension and discomfort. Timely diagnosis and intervention are essential to prevent complications. Small intestinal obstructions typically present with cramping, colicky pain, along with nausea and vomiting. In contrast, obstructions in the large intestine are more likely to cause lower abdominal distension and dull, persistent pain. These signs help differentiate the site and severity of the blockage. Prompt diagnosis is essential to prevent complications such as perforation or ischemia. Gastritis is the inflammation of the stomach lining and can be acute or chronic. Acute gastritis often results from injury to the mucosal barrier caused by medications, alcohol, or infection. Chronic gastritis is classified into 2 types: Fungal type A, which is immune-related, and antral type B, which is more often linked to H. pylori infection. Symptoms are often vague and may include anorexia, fullness, or epigastric pain. Peptic ulcer disease involves the breakdown of the stomach or duodenal lining, creating erosions or ulcers. These lesions can be acute or chronic and vary in depth from superficial to deep. While most ulcers occur in the stomach or duodenum, some can develop in the esophagus. Zollinger-Ellison syndrome, a rare condition, can lead to severe ulceration due to excess acid production. This slide offers a visual overview of the types of peptic ulcers. Superficial ulcers involve only the mucosa, while deep ulcers may penetrate the muscularis. Understanding the depth and location of an ulcer helps determine its severity and the best treatment approach. The image serves as a helpful diagnostic reference. Duodenal ulcers are the most common type of peptic ulcer and are strongly associated with Helicobacter pylori infection and NSAID use. These ulcers cause epigastric pain that often improves after eating or taking antacids. The pain tends to be intermittent but can become chronic if untreated. Management focuses on eradicating the infection and reducing acid production. This slide credits Dr. David Bjorkman for his contributions to gastroenterology education and clinical visualization. His work supports a deeper understanding of ulcer pathophysiology and patient care. Referencing his materials adds authority to our discussion of peptic ulcer disease. Visuals like these can be especially helpful in clinical training. Gastric ulcers often develop in the antral region of the stomach and differ from duodenal ulcers in key ways. Here, the primary problem is increased permeability of the mucosa to hydrogen ions. Interestingly, gastric acid production may be normal or even reduced. Unlike duodenal ulcers, food intake often makes gastric ulcer pain worse rather than relieving it. This slide continues the discussion of gastric ulcers by emphasizing that clinical manifestations often overlap with duodenal ulcers. However, the timing and nature of pain can help distinguish the two. Treatment strategies are similar and focus on acid suppression and mucosal protection. Addressing the root cause, such as H. pylori infection, is essential for healing. Stress ulcers are a form of acute peptic ulceration that develop in response to severe illness or trauma. Ischemic ulcers may appear within hours of events like burns, sepsis, or heart failure. Curling ulcers are associated with burn injuries, while Cushing ulcers are linked to brain trauma or surgery. These lesions are serious and require aggressive treatment to prevent complications like bleeding or perforation. When peptic ulcers fail to respond to medical therapy or complications arise, surgery may be necessary. The most common indications include recurrent bleeding or perforation of the stomach or duodenum. Surgical goals include reducing acid secretion, decreasing acid-producing cells, and repairing anatomical damage. While effective, surgery carries risks and is typically reserved for severe cases. Postgastrectomy syndromes are a group of complications that may occur after part or all of the stomach is surgically removed. These include dumping syndrome, alkaline reflux gastritis, and afferent loop obstruction. Additional issues like diarrhea, weight loss, anemia, and bone disorders may also arise. Each syndrome has distinct clinical features and requires tailored management strategies. Malabsorption syndromes occur when the digestive system cannot properly digest or absorb nutrients. Maldigestion refers to the failure of chemical processes, while malabsorption involves issues with mucosal uptake. Often, both occur together, leading to significant nutritional deficits. These conditions are especially problematic in chronic gastrointestinal diseases. Pancreatic exocrine insufficiency results from inadequate production of digestive enzymes like lipase, amylase, trypsin, and chymotrypsin. Causes include chronic pancreatitis, pancreatic cancer, or cystic fibrosis. The main symptom is fat maldigestion, which presents as greasy, foul-smelling stools and weight loss. Treatment involves enzyme replacement and dietary support. Lactase deficiency, also known as lactose intolerance, prevents the breakdown of lactose into absorbable sugars. As undigested lactose ferments in the colon, it produces gas, bloating, and osmotic diarrhea. This condition is common and can be diagnosed with breath tests or dietary elimination. Avoiding dairy or using lactase supplements helps manage symptoms. Bile salt deficiency impairs fat emulsification and absorption, leading to steatorrhea and fat-soluble vitamin deficiencies. This can occur in liver disease or bile duct obstructions where bile flow is reduced. Symptoms include greasy stools, diarrhea, and poor absorption of vitamins A, D, E, and K. Supplementation and treating the underlying condition are crucial. Fat-soluble vitamin deficiencies can have wide-ranging effects. Vitamin A deficiency causes night blindness, while vitamin D deficiency leads to bone pain, osteoporosis, and fractures. A lack of vitamin K impairs clotting, resulting in purpura and petechia. Vitamin E deficiency is less well understood but may contribute to neurological problems. Inflammatory bowel diseases, such as ulcerative colitis and Crohn's disease, are chronic, relapsing conditions that affect the intestinal tract. These disorders are influenced by genetic predisposition, environmental triggers, and immune dysregulation. Disruption of the intestinal barrier allows for exaggerated immune responses to gut flora. Treatment aims to reduce inflammation and manage symptoms over the long term. Ulcerative colitis is a chronic inflammatory disease that primarily affects the mucosal lining of the colon. It usually begins in the rectum and can spread proximally to involve the entire colon. The disease follows a pattern of flare-ups and remissions, and inflammation is continuous, not patchy. Over time, ulceration may lead to complications like bleeding, strictures, or toxic megacolon. This slide presents striking visual comparisons of inflammatory bowel disease in the colon. Image A shows the classic gross appearance of ulcerative colitis. The colon appears reddened, friable, and inflamed, with continuous mucosal involvement. In Image B, we see the hallmark cobblestone appearance of Crohn's disease, where patchy areas of inflammation alternate with normal tissue. These skip lesions create a rugged, uneven texture in the bowel lining. Image C shows transmural inflammation in Crohn's disease, which affects the full thickness of the bowel wall, often leading to strictures or fistula formation. These visual differences are key for diagnosing and distinguishing between ulcerative colitis and Crohn's disease during surgical or endoscopic evaluation. Symptoms of ulcerative colitis include frequent diarrhea, often up to 20 times per day, accompanied by urgency and bloody stools. Patients may also experience cramping and abdominal discomfort. Treatment is tailored to the severity of symptoms and extent of inflammation. Management includes anti-inflammatory drugs, immunosuppressants, and sometimes surgery. Crohn's disease is an idiopathic inflammatory disorder that can affect any part of the gastrointestinal tract from mouth to anus. Unlike ulcerative colitis, the inflammation in Crohn's is transmural and discontinuous, leading to skip lesions. These patchy areas of inflammation can cause narrowing, fistula formation, and malabsorption. Genetic and environmental factors both play a role in disease development. One hallmark of Crohn's disease is the development of deep ulcerations that may form fissures and penetrate the bowel wall. Symptoms often mirror those of ulcerative colitis, including diarrhea and abdominal pain. Anemia may occur due to malabsorption of vitamin B12 and folic acid. Treatment strategies are similar and include corticosteroids, immunomodulators, and sometimes biologic agents. Microscopic colitis is a relatively common cause of chronic, non-bloody diarrhea, especially in older adults. It comes in two main forms, lymphocytic and collagenous colitis. Although the exact cause is unknown, the inflammation is only visible under a microscope. Patients may present with watery diarrhea, but often have normal findings on colonoscopy. This slide clearly contrasts the pathologic features of Crohn's disease and ulcerative colitis. On the left, Crohn's disease is shown affecting the small intestine with transmural inflammation, meaning all layers of the intestinal wall are involved. Notice the skip lesions, where inflamed areas are separated by segments of healthy tissue, and the presence of strictures and fissures that can lead to obstruction. On the right, ulcerative colitis involves the large intestine, beginning in the rectum and progressing continuously upward. The inflammation here is limited to the mucosa and may lead to pseudopolyps, superficial ulceration, or atrophy in inactive stages. These distinct patterns help clinicians differentiate the two diseases in diagnosis and treatment planning. Irritable bowel syndrome, or IBS, is a functional gastrointestinal disorder characterized by abdominal pain and altered bowel habits. It is more common in males and often associated with stress, anxiety, and depression. Though it causes significant discomfort, IBS does not result in structural damage. The exact cause is unknown but may involve brain-gut communication disruptions. There are several proposed mechanisms for IBS, including visceral hypersensitivity, increased intestinal permeability, and abnormal motility. Post-infectious inflammation, food sensitivities, and dysbiosis of gut microbiota may also contribute. Psychological factors like stress and trauma can exacerbate symptoms. It is a complex and multifactorial condition. Patients with IBS often report lower abdominal pain, bloating, and changes in bowel patterns. It can present as diarrhea predominant, constipation predominant, or a mix of both. Unlike inflammatory bowel diseases, IBS symptoms are typically relieved by defecation and do not cause nocturnal symptoms. There is no cure, but treatment focuses on symptom control and lifestyle adjustments. Diverticular disease involves the formation of pouches, or diverticula, in the colon wall, particularly in the sigmoid colon. Diverticulosis is the presence of these pouches without inflammation and is often asymptomatic. When the diverticula become inflamed, the condition is known as diverticulitis. Risk factors include low-fiber diet, constipation, and aging. Diverticula can develop at weak spots in the intestinal wall and may lead to complications such as abscesses, fistulas, or perforation. Symptoms of uncomplicated diverticulosis may be mild or absent. In contrast, diverticulitis can cause fever, abdominal pain, and leukocytosis. Treatment ranges from dietary modification to antibiotics or surgical intervention, depending on severity. This endoscopic image shows the inner lining of a healthy colon. The mucosa appears smooth, moist, and glistening with a consistent pink coloration. There are no signs of inflammation, ulceration, or abnormal growths such as polyps. The regular circular folds and absence of bleeding or lesions confirm the mucosa is intact and functioning normally. This visual serves as a helpful reference point when comparing with pathological images of inflammatory bowel disease or colorectal cancer. Appendicitis is the inflammation of the vermiform appendix and is one of the most common abdominal emergencies. It typically results from obstruction of the appendix lumen by fecalates, foreign bodies, or infection. Early symptoms include vague periumbilical pain that later localizes to the right lower quadrant. If untreated, the appendix may rupture, leading to peritonitis or abscess formation, serious complications that require immediate surgical intervention. Mesenteric vascular insufficiency refers to inadequate blood flow to the stomach or intestines. It may result from thrombosis, embolism, or chronic atherosclerosis of the mesenteric arteries. Acute insufficiency can cause sudden, severe abdominal pain and carries a high mortality rate if not promptly treated. Chronic ischemia often presents as postprandial pain and weight loss due to fear of eating. One major complication of liver disease is portal hypertension, which is elevated pressure in the portal venous system. This occurs when there is increased resistance to portal blood flow, often due to cirrhosis. It leads to serious consequences such as varices, ascites, and splenomegaly. Proper management is essential to prevent life-threatening hemorrhage. As portal hypertension worsens, it can lead to the development of esophageal varices, splenomegaly, and syndromes such as hepatopulmonary and portopulmonary hypertension. The most alarming symptom is vomiting of blood from ruptured varices, which requires emergency care. These complications reflect the systemic effects of impaired liver function and circulation. This slide offers a visual reference from Monahan's medical surgical nursing text, showing the anatomy and effects of portal hypertension. It reinforces how liver dysfunction affects not just hepatic circulation, but also pulmonary and renal systems. Clinicians rely on these images for educational and diagnostic clarity. Understanding vascular flow through the liver is crucial in managing cirrhotic complications. Ascites is the accumulation of fluid in the peritoneal cavity, often due to cirrhosis-related portal hypertension and hypoalbuminemia. This causes abdominal distension, weight gain, and discomfort. Other contributing factors include splanchnic vasodilation and renal sodium retention. Management includes diuretics, sodium restriction, and in some cases, paracentesis to remove excess fluid. This flowchart breaks down how cirrhosis leads to the development of ascites. Cirrhosis causes portal hypertension, which increases lymph production and filtration pressure, leading to fluid leakage into the peritoneal cavity. At the same time, splanchnic vasodilation and translocation of gut bacteria may contribute to bacterial peritonitis and further increase capillary permeability. On the other side, hepatocyte failure results in decreased albumin synthesis, reducing capillary oncotic pressure. This leads to lower plasma volume and renal perfusion, which activates hormones like aldosterone, causing the kidneys to retain sodium and water. The end result of these combined pathways is fluid accumulation in the abdomen, known as ascites, a hallmark complication of decompensated liver disease. This image shows a dramatic case of severe ascites, a common complication of end-stage liver disease. The patient's abdomen is visibly distended due to excessive fluid accumulation in the peritoneal cavity. Prominent veins, skin striae, and an umbilical hernia are also present, hallmarks of long-standing portal hypertension. This physical presentation emphasizes the critical need for fluid management, monitoring of renal function, and early intervention to prevent further decompensation in cirrhotic patients. Hepatic encephalopathy is a serious neurologic condition resulting from liver dysfunction. Toxins, particularly ammonia, bypass the liver and affect brain function, causing behavioral, cognitive, and motor changes. It may present suddenly in fulminant hepatitis or gradually in chronic liver disease. Early recognition and treatment with medications like lactulose are essential to reverse symptoms. Hepatic encephalopathy progresses in stages, beginning with subtle personality changes and progressing to severe cognitive and motor deficits. Early symptoms may include irritability, disinhibition, memory loss, and sleep disturbances. As the condition worsens, patients may develop confusion, asterixis, or flapping tremors of the hands, slow speech, and even coma. Management focuses on reducing ammonia levels, often using lactulose or rifaximin. Jaundice, or icterus, is a yellow discoloration of the skin and sclera caused by elevated bilirubin levels. It may result from extrahepatic or intrahepatic obstruction, or from hemolysis. Obstructive jaundice typically produces dark urine and pale stools, while hemolytic jaundice leads to elevated unconjugated bilirubin. Recognizing the type of jaundice helps narrow down the underlying liver or biliary condition. This slide continues the discussion on jaundice and reinforces the role of impaired bilirubin metabolism in liver disease. Whether the obstruction is intrahepatic or extrahepatic, the buildup of bilirubin in the blood reflects severe liver dysfunction. It's essential to assess liver enzymes, bilirubin fractions, and imaging to determine the source. Timely diagnosis can prevent complications like cholangitis or irreversible liver damage. Hepatorenal syndrome is a type of renal failure seen in patients with advanced liver disease. It's functional, meaning the kidneys are structurally normal but fail due to poor blood flow. Type 1 is rapid and severe, while type 2 is slower and more chronic. Symptoms include oliguria, low blood pressure, and signs of liver failure. This condition has a very poor prognosis without liver transplantation. Acute liver failure is a rare but life-threatening condition where massive liver cell injury occurs without prior liver disease. In the United States, the leading cause is acetaminophen overdose. Patients present with jaundice, coagulopathy, encephalopathy, and rapid clinical deterioration. Early recognition and referral for transplant evaluation are critical. Cirrhosis is an irreversible condition where chronic liver inflammation leads to fibrosis and nodular regeneration. As bile ducts become obstructed, portal hypertension worsens and liver function declines. The progression and severity depend on the underlying cause, such as alcohol abuse, hepatitis, or non-alcoholic fatty liver disease. Once cirrhosis sets in, management focuses on preventing further damage and treating complications. This slide compares two livers severely damaged by chronic liver disease. Image A shows a liver with micronodular cirrhosis, typically associated with long-term alcohol abuse. The surface is irregular, with small regenerative nodules surrounded by fibrous bands. Image B presents macronodular cirrhosis, often seen in post-hepatic cirrhosis, such as from chronic viral hepatitis. Here, large nodules form amidst dense fibrotic tissue, distorting the organ's architecture. Both forms lead to portal hypertension and loss of liver function, emphasizing the destructive nature of chronic inflammation and the importance of early intervention. This slide continues with the morphological and structural changes in cirrhotic liver tissue. Over time, fibrous bands replace normal architecture, limiting hepatic blood flow and impairing detoxification. The liver becomes firm, nodular, and shrunken. These irreversible changes the importance of early intervention in chronic liver disease. Alcoholic liver disease progresses through stages: fatty liver, steatohepatitis, and ultimately cirrhosis. Symptoms such as anorexia, jaundice, and edema indicate advanced disease. Continued alcohol consumption accelerates liver damage, increasing the risk of liver failure and cancer. Abstinence, nutritional support, and corticosteroids in select cases are key components of management. Non-alcoholic fatty liver disease, or NAFLD, is the buildup of fat in the liver that occurs in people who drink little or no alcohol. It is increasingly common and strongly associated with obesity, diabetes, and metabolic syndrome. Over time, it may progress to non-alcoholic steatohepatitis, or NASH, which can lead to fibrosis, cirrhosis, and liver failure. Early lifestyle intervention is critical to halt disease progression. Primary biliary cholangitis is a chronic autoimmune liver disease that targets small bile ducts within the liver. This slowly progressive condition often coexists with other autoimmune disorders and leads to bile accumulation, liver damage, and eventually cirrhosis. Patients may experience itching, jaundice, and pale stools as bile excretion becomes impaired. Treatment focuses on managing symptoms and slowing disease progression with medications like ursodeoxycholic acid. Viral hepatitis refers to systemic viral infections that primarily target the liver. The five major types, hepatitis A, B, C, D, and E, differ in mode of transmission, severity, and chronicity. Hepatitis B and C are the most common causes of chronic liver disease and liver cancer. Some infections are self-limiting, while others require long-term antiviral therapy. Viral hepatitis progresses through several phases. The incubation period, the prodromal phase with nonspecific symptoms, the icteric phase marked by jaundice, and the recovery phase. In some cases, especially with hepatitis B and C, the infection becomes chronic. Chronic active hepatitis can lead to liver fibrosis and cirrhosis over time. Vaccination and early treatment are key in reducing disease burden. Gallstones, or cholestasis, form when substances in bile, such as cholesterol or bilirubin, crystallize in the gallbladder. Risk factors include obesity, middle age, female sex, rapid weight loss, and certain genetic backgrounds. Many people with gallstones are asymptomatic, but others experience pain, especially after eating fatty foods. If stones obstruct bile flow, serious complications can occur. Gallstones vary in composition and appearance. Cholesterol stones are the most common and form when bile becomes oversaturated with cholesterol. Pigmented stones, which are either brown or black, are associated with infections or chronic hemolytic diseases. Understanding the stone type can guide treatment and prevention strategies. Diet, weight management, and surgery are all therapeutic considerations. Clinically, gallstones may be asymptomatic or produce vague symptoms such as right upper quadrant pain and bloating. Pain often arises after consuming fatty meals and may radiate to the back or shoulder. When stones block the cystic or common bile duct, patients may develop more serious complications like cholecystitis or cholangitis. Diagnosis is usually confirmed via ultrasound. This slide provides an anatomical illustration of gallstone formation and bile flow dynamics. It visually supports the pathogenesis of cholelithiasis by demonstrating how impaired metabolism of bile components leads to stone development. These visual aids help bridge textbook theory and real-world patient care. Understanding these mechanisms supports more effective diagnosis and management. Cholecystitis is inflammation of the gallbladder, most commonly caused by a gallstone lodged in the cystic duct. Patients may present with right upper quadrant pain, fever, nausea, and rebone tenderness. If untreated, complications such as gangrene or perforation can develop. Management often involves antibiotics and, in severe cases, cholecystectomy. Pancreatitis is inflammation of the pancreas, usually caused by gallstones or alcohol-induced injury. When digestive enzymes become activated within the pancreas, they begin to digest pancreatic tissue, leading to inflammation and pain. Obstruction of pancreatic outflow plays a central role. Symptoms include severe epigastric pain that radiates to the back and worsens after eating. Acute pancreatitis is often mild and self-limiting, but in some cases, it can be life-threatening. Causes include alcohol abuse, viral infections, and medications. Chronic pancreatitis, on the other hand, leads to progressive destruction and fibrosis of the pancreas. It often presents with chronic abdominal pain and weight loss, and may increase the risk of pancreatic cancer. This flowchart illustrates the cascade of events that lead to acute pancreatitis. The process begins with acinar cell injury or duct obstruction, which causes enzyme activation within the pancreas itself. Enzymes like trypsin, chymotrypsin, and lipase begin autodigesting pancreatic tissue, resulting in fat necrosis, hemorrhage, and widespread inflammation. Cytokine release further amplifies injury, leading to systemic complications such as shock, sepsis, acute respiratory distress syndrome, and multi-organ failure. In severe cases, intestinal bacterial translocation can occur, leading to pancreatic abscesses or pseudocyst formation. Understanding this mechanism is critical for prompt diagnosis and intervention. This slide contrasts two pathological specimens of the pancreas. Image E shows a relatively normal pancreas in terms of size and color, offering a baseline for comparison. In contrast, Image B reveals a pancreas ravaged by acute hemorrhagic pancreatitis. You can see areas of dark hemorrhage, fat necrosis, and extensive tissue destruction. This dramatic transformation illustrates how quickly pancreatic inflammation can progress from localized injury to life-threatening systemic damage. Such visuals reinforce the importance of early recognition and aggressive management in cases of severe pancreatitis. Esophageal cancer can be either squamous cell carcinoma or adenocarcinoma. Squamous type is linked to smoking and alcohol use, while adenocarcinoma is associated with GERD and obesity. Common symptoms include dysphagia and chest pain. Early detection is difficult, and prognosis depends heavily on the stage at diagnosis. Stomach cancer is often associated with Helicobacter pylori infection, atrophic gastritis, and dietary factors like smoke or salted foods. In early stages, symptoms are vague, such as indigestion or loss of appetite. As the disease progresses, patients may present with weight loss, vomiting, and anemia. Because early symptoms are subtle, diagnosis is often delayed. This image shows a dramatic example of a gastric ulcer penetrating the stomach lining. You can clearly see the large, crater-like lesion surrounded by inflamed and thickened mucosa. The ulcer base appears discolored and necrotic, indicating ongoing tissue breakdown and possible bleeding risk. This type of lesion typically results from Helicobacter pylori infection, NSAID use, or excessive acid secretion. Without treatment, such ulcers can lead to perforation, hemorrhage, or obstruction, serious, potentially life-threatening complications. Colon and rectal cancers are among the most common cancers in developed countries. They result from genetic mutations and environmental factors like low-fiber diets and sedentary lifestyles. Hereditary syndromes, such as familial adenomatous polyposis, significantly increase risk. Screening and early removal of polyps are key strategies in prevention. This slide shows two examples of gastric cancer, highlighting different growth patterns. Image A illustrates a fungating tumor labeled A, protruding into the gastric lumen. The adjacent tissue labeled appears flattened and stretched, likely due to the mass's expansion. Image B presents a cauliflower-like tumor, an advanced case of adenocarcinoma, with a highly irregular surface indicating aggressive growth. These visual presentations are classic signs of invasive gastric malignancies, which often go undetected until late stages due to vague early symptoms like indigestion or weight loss. This slide summarizes the spectrum of colorectal neoplasia, from benign polyps to invasive adenocarcinoma. Symptoms often develop late and include changes in bowel habits, rectal bleeding, and unexplained anemia. Regular colonoscopy screening is vital, especially in those with a family history. Treatment typically involves surgery, chemotherapy, and sometimes radiation. Liver cancer is often metastatic, spreading from other primary tumors, but hepatocellular carcinoma can arise from chronic hepatitis or cirrhosis. Symptoms are often silent until the disease is advanced. When present, they may include right upper quadrant pain, weight loss, and jaundice. Surveillance is critical in high-risk patients, especially those with chronic hepatitis B or C. This image displays a liver affected by hepatocellular carcinoma, the most common primary liver cancer. The surface is nodular and irregular, with large pale, yellow-white tumor masses replacing healthy liver tissue. These masses disrupt normal architecture and indicate aggressive tumor infiltration. This cancer most often arises in the setting of chronic liver disease, such as hepatitis B, hepatitis C, or cirrhosis. Because symptoms develop late, regular screening in high-risk patients is crucial for early detection and intervention. Gallbladder cancer is rare and typically diagnosed at a late stage. Chronic inflammation, gallstones, and infection with certain bacteria can contribute to its development. Early symptoms are often absent or nonspecific. By the time it's detected, the cancer has often spread, making surgical cure difficult. Pancreatic cancer, particularly ductal adenocarcinoma, arises from the exocrine cells lining the pancreatic ducts. This form of cancer is highly aggressive and often diagnosed at an advanced stage. Chronic pancreatitis and prolonged inflammation play a role in tumor development. By the time symptoms like weight loss, back pain, and jaundice appear, the cancer is typically no longer curable, making early detection essential yet challenging.